everyone. Welcome in. Thank you all for being here. We are going to go get started due to the sake of time, but thank you all for being here. So welcome everyone. Thank you so much for joining today's webinar, Reducing the Risk of Hepatitis B, Cultural Considerations for Hepatitis B Screening and Prevention. My name is Mary Grace and I'm a program manager at the Asian Health Coalition, and I will be one of your moderators today alongside Sheila Giovanni from Cook County Department of Public Health. A few reminders before we get started. This webinar is being recorded and will be posted to our Asian Health Equity YouTube channel. That link will be shared with you, so feel free to go back, listen to the webinar again, and share it with your colleagues. There is a Q&A section at the bottom of your screen where you are free to type your questions. If time allows, at the end of the webinar, we will ask our speaker to answer any of those questions. If we do not have time, please submit your question in the short post-webinar survey that should pop up following the conclusion of this webinar. We will send a follow-up email answering any questions that we did not have time to get to. As many of you may already know, May is Hepatitis Awareness Month. This webinar, Reducing the Risk of Hepatitis B, Cultural Considerations for Hepatitis B Screening and Prevention, is one webinar among a two-part series that is intended to raise awareness about hepatitis B. This series is a collaboration between Cook County Department of Public Health and Asian Health Coalition. With that, I will pass things along to Sheila Giovanni from Cook County Department of Public Health to introduce our guest speaker.
Thank you, Mary Grace. My name is Sheila Giovanni, and I am the Vaccine Preventable Disease Manager at Cook County Department of Public Health. I am excited about the partnership with the Asian Health Coalition and to bring forth today's insightful presentation. I have the honor to introduce our speaker of the hour, Dr. Matthew A. Odenwald, who is a gastroenterologist and a hepatologist at the University of Chicago Medical Center. He received his medical degree from the University of Chicago Pritzker School of Medicine and is currently a hepatologist fellow and has been practicing for 6 years. Thank you. Dr. Matthew Odenwald, please.
All right. Hello, thank you for the introduction. I'm going to share my screen now. I think everyone can see my screen. Again, my name is Matt Odenwald, and I'm a current hepatology fellow at the University of Chicago. And today I'll be discussing hepatitis B. So as many of you may be aware, there's a lot of ground to cover with the hepatitis B. So my talk is going to focus on the epidemiology and global prevalence of the virus, and then the natural history of a hepatitis B infection, risk factors for the infection, and then how to screen for hepatitis B, including what blood tests and serologies we can order for this, which can often be confusing, and how to diagnose different phases of the disease. And that's prior to discussing both treatment options and prevention for hepatitis B. And then finally, given both the global epidemiology of hepatitis B and the routes of transmission of acute infections in many parts of the world, it's really important that we touch on different culturally appropriate conversations around the virus. So this is a little bit old data, but back in 2006, there were an estimated 360 million people living with chronic hepatitis B in the world, and that included over 6 million children under the age of 5. There's really striking geographic variation in the epidemiology of chronic hepatitis B infections, and endemic regions, including sub-Saharan Africa, shown here in the dark blue, certain parts of Southeast Asia and parts of South America, where the prevalence is estimated to be about 8 to 10% of the entire population. And that's compared to the rest of the world, where the prevalence is far less than 2% in many parts of the world. So it's a quite a prevalent disease. Hepatitis B can really come in 2 different flavors. One is the acute hepatitis B infection, and the other is chronic hepatitis B infection. So acute hepatitis B infection is depicted here in the top, and this rarely causes symptoms. And in immunocompetent adults or even older children, if symptoms are present, it's typically a very self-limited hepatitis with vague symptoms of sometimes fevers, fatigue, nausea, vomiting, and occasionally jaundice. And in the overwhelming majority of patients who have competent immune systems who contract hepatitis B. This is a self-limited infection that clears and does not cause any form of chronic disease. That's in contrast to many parts of the world where hepatitis B is endemic, and this often infects neonates through vertical transmission and can infect immunocompromised adults. In these patients, the majority is transmitted vertically from mother to baby, and due to lack of developed immune system, there's greater than 90% transmission rate from mothers to infants, and this can result in chronic hepatitis B infection. So in early stages, and even stages of cirrhosis, these are often completely asymptomatic individuals. However, there is a risk of progression from cirrhosis to even developing hepatocellular carcinoma or liver cancer. And overall, there's about a 25% risk of developing hepatocellular cancer with chronic hepatitis B. And there's an estimated 820,000 deaths worldwide from hepatitis B annually. And so because these early stages of hepatitis B and even some patients in late stages are often very asymptomatic, it's really important to understand the risk factors for developing chronic hepatitis B and the ways that we can screen for it in order to get early treatment of these patients. So hepatitis B is a bloodborne pathogen, and risk factors for infection include blood-to-blood contacts, and this includes healthcare workers that can get needle sticks and blood transfusions prior to us screening for hepatitis B. It can also be transmitted through sexual contact, IV drug use, men who have sex with men, and even household contacts. But as I mentioned, the most common form of transmission for hepatitis B is vertical transmission from mother to baby. And this is the most common route of infection worldwide. As I mentioned, many in this first group with the blood-to-blood contact, sexual contact, IV drug use, and so forth, often have a very self-limited acute hepatitis B infection, whereas vertical transmission typically results in chronic hepatitis B due to immune system development. And this is highlighted in the graph here with the risk of chronic hepatitis B infection by different age. So in neonates, there's an over 90% risk of developing chronic hepatitis B, and that rapidly decreases in infants where it's about 50%, in older children where it's less than 20%, and in adults it's far less than 5%, 1 to 2% who are exposed to hepatitis B will go on to develop chronic hepatitis B, and the risk factors for developing chronic hepatitis B are often immune dysfunction. So knowing the risk factors for hepatitis B can really help determine who we should screen for in the clinic. And this includes everyone who is born in or lived in endemic regions. And this is Asia, but particularly Southeast Asia, Sub-Saharan Africa, Eastern Europe, and certain regions of South America. Also in the United States, we often have to think about screening people with risk factors for bloodborne contact, as I mentioned earlier. And this includes, I didn't mention earlier, but patients who have hepatitis C or HIV, they're at risk for having hepatitis B as well. And patients who are on hemodialysis because they have a lot of exposures to the healthcare system and a lot of needle sticks as well. We screen all pregnant patients to attempt to prevent vertical transmission. And then patients who are going to undergo immunosuppressive therapy should be screened as well to prevent flares. Screening is typically done with very simple blood tests, and we typically use the hepatitis B surface antigen, core antibody, and surface antibody. And then if they're negative for these, we typically recommend a vaccine to prevent against infection. So I'll go over these serologies in the next slide. So what is hepatitis B? It's a DNA virus and has many different components and many different genotypes. The genotypes aren't necessarily that clinically important and not important for our talk today, but the parts of the virus can be a little bit confusing and really need to understand them in order to understand some of the different serologies. So the parts of the virus include this circular DNA, and that can actually integrate into the host cells and set up shop within the hepatocytes and stay there dormant for years. These are surrounded by the core proteins, which is the hexagon shown here, and then envelope proteins, as well as surface antigens. And each of these can be tested with DNA viral load, the surface antigen and antibodies, core antibodies, both total and IgM core antibodies, and then envelope proteins, the E antigen and E antibodies against the envelope proteins can be tested as well. So what do these each tell us? So if you have a surface antigen, that tells us that there is an infection, but it doesn't necessarily tell us if it's an acute infection or a chronic infection. The surface antibody tells you that there's immunity against the surface antigen. So it tells you that they could have been infected and developed immunity, or developed this antibody, or they could have had the vaccine. The IgM core antibody, so IgM is the first antibody to arise and tells you about an acute infection. And that's in contrast to the IgG core antibody that can tell you that the patient was infected either in the past or could still have a hepatitis B infection. And then the most confusing tend to be these envelope antigens and antibodies. And E antigen is really a marker of whether or not the patient is actively infective. So it can be very effective against towards another person. So there's a couple more slides that I've got on these just to hammer these home a little bit, because these can be quite confusing. So how do we interpret some of these serologies that we just went over? So if a patient does not have surface antigen, is negative for core antibodies, total and IgM, and negative for surface antibody, this patient is completely hepatitis B naive, and they've never been infected, and they have not received a vaccine. If the surface antigen and core antibody, the total core antibody, are positive, but the IgM and surface antibody are negative, we would say that this patient has a chronic infection, and then we would do further testing to see the stage of that chronic infection. If the surface antigen and both total and IgM core antibody are positive, but the surface antibody is negative, we would conclude that this patient has an acute infection. And if both the core antibody and surface antibody are positive, but others are negative, this patient has recovered from a prior infection. So it's often those patients who would get an acute chronic hepatitis B infection, but then clear the infection. And then finally, the one that we often get referrals for in the hepatology clinic is probably the best hepatology referral we can get, because this is the best news we can give a patient. They have surface antibody reactivity, but then everything else is negative. We get to tell a patient that they're actually immune from a vaccine to hepatitis B, and they're not at risk for hepatitis B. So finally, there's one more slide that I wanted to go over. Give me one sec. There's one more slide for an illustration of these serologies. And this has an acute self-limited infection above, and then I'll go over chronic infection, so the stages of it. So for an acute self-limited infection, the DNA shown in royal blue, the surface antigen shown in purple, and then the E antigen shown in the surface antigen shown in magenta and the E antigen shown in the purple, they rise pretty rapidly. And this is followed by rises in the core antibody as well as their liver enzymes, so like the ALT shown in green here. In an acute self-limited infection, all of these fall, except for the core antibody, which remains positive over the patient's lifetime. And the surface antibody also remains positive over the patient's lifetime as well. But then the DNA and the E antigen all rise and actually become undetectable and oftentimes negative throughout the patient's life. That's in contrast to patients who develop a chronic infection. And in the chronic infection, all of the same markers rise rapidly. However, the hepatitis B viral DNA can remain high, or can remain very high, or can be at different levels throughout the lifetime of the patient. But the core and surface antigen and core and surface antibody can often be high over the patient's lifetime as well. So once we've made the diagnosis of chronic hepatitis B, which is really the focus of this talk, there's really two main goals once we've made this diagnosis. One is to determine who should be treated with antivirals, and the other is to determine who needs to be screened for the progression to advanced fibrosis or cirrhosis, and also who needs to be screened for hepatocellular carcinoma. So I'll start with the first one, which is who needs to be screened for hepatocellular carcinoma. So everyone with cirrhosis, regardless of cause, needs to be screened regularly for HCC. And this screening is done at least every 6 months, typically with a blood test measuring an alpha fetoprotein level, which is generated by liver cells that are undergoing rapid turnover, and with imaging that can either be with an ultrasound or oftentimes with an MRI liver, but it has to be a specific liver protocol with 3 phases for arterial, venous, and delayed washout phase for the MRI or a CT scan that's done. So everyone with cirrhosis, regardless of cause, needs these every 6 months. And then in addition to everyone with cirrhosis, select groups without cirrhosis need to be screened more frequently for hepatocellular carcinoma. And this is based on the risk factors from populations with the genotypes that are common in these endemic areas and the patients, the ages of patients and the risk factors for developing HCC. So this includes patients of Asian descent who are male and over 40 years old. They all need to be screened. Asian females over 50 years old need to be screened. Anyone with a family history of HCC should be screened. And then patients of African descent with hepatitis B virus have a very high risk of developing HCC because of the genotypes that are there. And they should all be screened at starting at age 20 years old or older. So I think that once we determine that who needs to be screened, we should do this every 6 months with an AFP and at least an ultrasound. My personal practice is to alternate an ultrasound and an MRI if insurance will allow me to, because it gives oftentimes a better picture of the liver. So this slide is kind of helping us determine who needs to be treated. And I'll go through it step by step, because looking at it, it is incredibly confusing. And even to someone who treats hepatitis B in the clinic fairly often, it can still be a confusing thing. And I need to go through this fairly often. So it's important to know that hepatitis B has several stages, and that not everyone with hepatitis B, even with active hepatitis B, meets criteria for getting antiviral treatment, at least by the guidelines. So the first phase of hepatitis B is called the immunotolerant phase. These patients have, their serologies would show that they have a surface antigen positive. They have incredibly high viral loads, but they have normal liver chemistries or normal liver enzymes. And so there's no necrosis and no inflammation within the liver. These patients do not need to be treated with, antivirals. Patients with the immunoactive phase, however, do need to be treated. And this is a patient who has surface antigen positive. They also have high viral loads, oftentimes greater than 20,000. But they do have increases in their liver enzymes, and they do have inflammation and sometimes necrosis in the liver. These patients have a very high rate of annual progression to cirrhosis, and they have a high risk of developing hepatocellular carcinoma. And so they should be treated with antiviral therapy to prevent the progression of cirrhosis and prevent the risk of HCC. So about 8 to 12% of these patients in the immunoactive phase per year will then become inactive carriers, where they have surface antigen positivity, they have low viral loads, they have ALT is normal, and they don't have necroinflammation. But many of them do have fibrosis if they've gone through this immunoactive phase. And so they're not necessarily a candidate for therapy, but if they have fibrosis, they should be treated with therapy. And then they can get exacerbations of hepatitis and then need therapy as well. So kind of the holy grail of hepatitis B treatment is what we would call resolution. And this is when you go from antigen positive or surface antigen positive to surface antigen negative and develop a surface antibody. The DNA is undetectable, ALT is normal, and there's no necrosis and no inflammation. And these patients Actually, once they've converted from surface antigen positive to negative and develop the antibody, they don't need treatment typically for the rest of their life. We're a little bit cautious in the hepatology clinic, and we'll oftentimes double check that a year later and then take patients off therapy and triple check it in another 6 months to a year to make sure that they would be safe to withdraw therapy from. This is really the holy grail of hepatitis B treatment. And then patients, finally in the bottom, patients can develop an E antigen negative hepatitis where they have the surface antigen is positive, the viral load is high, they have very high ALTs, they can have necroinflammation and fibrosis, and these patients have a very high annual rate of progression to cirrhosis and a very high rate of hepatitis C virus, and they should also be treated. So there's really, I know this is a bit confusing, and there's actually a push within the hepatology community. I'll go over the treatments in a couple of slides, but there's a push within some certain people within the hepatology community to say this is too confusing for most of the referring providers, and the medications do not have many risks, and so we should really be treating everyone. There is a thought of that out there today too. So this is the guideline recommended treatments, but there are some people who would say that we should just be treating everyone because it's simple, relatively cheap, and very effective. But this is the guideline recommended treatment and what most hepatologists would follow. So the goals of hepatitis B virus therapy, as I said, going from positive antigen to negative antigen and developing the surface antibody is really the holy grail. And this only happens in a total of 3 to 5% of patients, and it's incredibly rare though. And so even people who've been treating patients for decades have seen it just a couple of times in their career. So it's not something that we often expect. It's something we hope for. We don't have a way to make this happen, at least not yet. In E antigen positive patients, the goal is from seroconversion from E antigen positive to E antibody. And that shows you the marker of infectivity. And for E antigen negative patients, the goal is long-term hepatitis B virus DNA suppression, and these patients often require lifelong therapy. So what are the therapies that we can give patients? So the first, one of the earlier generations, many years ago, patients used to get really, really difficult to tolerate therapies like interferon therapies. Those are no longer the case. So the next generation was these nucleoside and nucleotide analogs like lamivudine. These aren't really used anymore because there is a higher resistance rates to these therapies. And now more popular is entecavir. This is often the first line if the patients are treatment naive, and tenofovir or TAF. And these are patients can get these if they have seen lamivudine before, if they've had resistance to entecavir, although it's very rare, and then it can be tolerated in pregnancy. And then there are certain other special populations like tenofovir can often be part of an antiviral regimen for patients with concomitant HIV as well. And so this can often be a dual therapy. So one special case that we often think about, especially given that there is such a high rate of developing chronic hepatitis B, if there's vertical transmission, is how do we treat women who are pregnant with a child and to prevent that child from getting chronic hepatitis B. So currently the guidelines only recommend treating if the viral load is very high. They only recommend treating starting in the 3rd trimester. Tenofovir is the preferred regimen. But even if the viral load is suppressed, the baby at birth, we recommend the vaccine at birth nearly almost immediately. And then patients also get something called hepatitis B immunoglobulin that together those do a really good job of preventing vertical transmission. Another special case is that once patients have been exposed, they will always have hepatitis B virus kind of integrated into the hepatocytes, even if it's undetectable within the serum. So in some patients, so this is a cartoon of a patient who has chronic or resolved hepatitis B infection. So you have really no detectable levels of hepatitis B virus in the serum, but in the hepatocytes, it's laying dormant. And then if these patients get an immunosuppressive drug, the hepatitis B can reactivate, replicate, and start causing pretty severe damage to the liver with a hepatitis B flare that can result in liver failure and sometimes even death. And in certain cases, in certain scenarios, reactivation rates can really be up to about 80%, depending on the surface antigen positivity and the immunosuppression regimen. So this is a chart of when we would prophylactically treat patients. So the risk in the left column is the risk level, the middle column is the clinical scenario, and then the recommendation is in the right column. So patients who are from moderate, greater than 1% risk of reactivation, we recommend prophylaxis in all of these patients. And these include patients who are surface antigen positive and are undergoing treatment with anti-CD20 treatment like rituximab, stem cell transplants, long courses of high-dose steroids, immunosuppression with alemtuzumab, getting cytotoxic chemotherapy, getting anti-TNFs like adalimumab or infliximab, or undergoing solid organ transplant. Patients who are surface antigen negative, but core antibody positive would suggest that they've had a past infection. And if they're undergoing rituximab treatment or stem cell transplant, they would still be considered having a moderate risk, and we would recommend prophylaxing against them as well. With lower dose immunosuppressions or different therapies, we typically would monitor patients with really frequent blood draws while they are undergoing therapy. And then if they reactivate, then we would treat patients. And the important thing is that we typically, if we do start prophylaxis or treatment during this, we treat for at least 12 to 18 months after this. And again, just like before with the treatment of hepatitis B, in these prophylaxis cases, entecavir and tenofovir are the preferred prophylactic agents. All right. And I know Sheila, as the vaccine, as the person who's really important with vaccines in the Cook County Health, that we should really talk about the hepatitis B vaccine because it's really considered to be a major public health success and a global health success as well. So on this blue line here is the rate of acute hepatitis B per 100,000 children aged 1 to 9 years in the United States. And in the dotted line here is the vaccine coverage rate. And what we can see is that once the universal infant hepatitis B vaccine was made available in the United States in the early 1990s, we saw dramatic uptake in the rates of vaccine coverage and a dramatic decrease in the rate of acute hepatitis B in infants. Similar things have been done in multiple countries around the world. And now there's a really ambitious goal from the World Health Organization, as well as multiple liver and infectious disease societies to actually eliminate chronic hepatitis B virus globally. And I think that they're making pretty great strides in this effort, although it's certainly not done yet. The work is not done yet. So who do we recommend the hepatitis B vaccine for? So right now there's universal recommendation in infants. So they should be vaccinated within the first year of life. They should be vaccinated. And previously we used to recommend it in kind of a catch-up vaccine in adults who are high risk. So this included patients with any form of chronic liver disease. So if they got hepatitis B, it could result in a pretty severe liver injury. Patients who have hepatitis C, HIV, or have other risk factors for bloodborne, for a blood-to-blood contact. However, in March of 2022, there was a recommendation just to recommend vaccination for all adults less than 60 years old who don't have markers of immunity. All right, so I think that concludes my portion on the screening, epidemiology, screening, and treatment and prophylaxis against hepatitis B. But kind of to bring it back to the epidemiology, we see from this global map that hepatitis B can affect patients of really all cultures and ethnicities. but does have a predilection for Southeast Asia, Sub-Saharan Africa, parts of Eastern Europe, and parts of South America. And so while it can affect all cultures and ethnicities, in the United States, we treat patients of all cultures and ethnicities, and so we really need to be aware of this as healthcare providers. So I think it helps to start out to define what a culture is. So it's the body of learned beliefs, traditions, principles, and that guides for behavior that are commonly shared among members of a particular group. And it serves as a roadmap for both perceiving and interacting with the world. And that's in contrast to ethnicity that refers to a particular social groups in complex societies, and groups are differentiated not only on the basis of a range of shared cultural content, but also on social attitudes and economic and political considerations as well. And both culture and ethnicity are important in healthcare because it can influence health-related behavior, access to healthcare, and then it can also, the lack of knowledge or sensitivity to different cultures can actually limit the ability for us as providers to provide quality healthcare and be aware of different things. So this is really highlighted in a now about 13 or 14-year-old New York Times article called Bridging the Culture Gap. And this is about a doctor and patient relationship. And so the next couple of slides just have a few excerpts from this piece. And so I'll give you a second to read it. But while you're reading, I'll say that this the writer of this had immigrated from China, and her mother had inoperable liver cancer. And about 20 years later, two of her brothers had it. And after the second one died, they had sifted through her medical records to find out that they had all had chronic hepatitis B that was not really detected earlier. And then one of her colleagues said, well, but what a pity. And he was shaking his head. If only one of the clinicians had seen earlier had been a little more aware of some of the health concerns of Asian Americans. And so this really highlights some of the knowledge of the epidemiology, but also some cultural and ethnic considerations that really should be taken into account when caring for patients. So how do we bridge this gap? So part of this relates to cultural competency, and then knowing that patients' cultural background can influence their kind of predilection to different diseases, but also their access to healthcare, communication with healthcare providers, and then the doctor-patient relationship in and of itself, as well as the experience of illness and the willingness to speak up and things like that. So what is cultural competence? So that's something that providers should seek to have. And so it's the knowledge and interpersonal skills that allow us to understand, appreciate, and work with individuals of cultures other than our own. And it involves both an awareness and an acceptance of cultural differences, a self-awareness of our own potential cultural biases, and a knowledge of the patient's culture and some adaptation of skills. And it's really necessary to be an effective clinician who can treat people from a variety of backgrounds and with a variety of disease states. So from a patient perceptions and the quality of care, cultural competency can give patients really a sense of hope. So communication isn't really just about language or interpreters and being able to speak and communicate the facts, the medical facts. It's also about being cognizant of what the patients are bringing with them and treating the patients as really a whole person. And this can be hard to do with time constraints. We often have 15-minute visits and have to tackle many, many different things. So it can be something that's really a practiced skill and not necessarily something that we are born with, but it's something that we need to practice over and over. And one of the important things, this isn't necessarily about outcomes, but it's really linked to patient satisfaction is patients who have a cultural competency. And this is really striking that this study here it surveyed quite a few patients of multiple different ethnicities, and they asked the question whether or not patients believe they would receive better healthcare if they themselves were a different race or ethnicity. And patients who are African Americans, Latinos, and Asian Americans, all with very high percentages, up to 15%, all said that they believe that they could receive better healthcare if they would be more satisfied with their healthcare if they were of a different ethnicity. So this highlights that even though as providers we're often trying to provide the best healthcare we can and trying to be cognizant of many things that patients bring with them, that we're often falling short. So this should bring a little bit of awareness to us. So how do we do this? It does not require us needing to have a lot of information. It's not something that you would study in a book and do a bunch of checklists, but it's really more about increased awareness. So being a bit aware of the cultural context that patients as well as doctors bring with them, and awareness of yourself in a little bit of a self-critical way, as well as knowing that providers can bring your own cultural orientation to a relationship, kind of being aware of that. So, because oftentimes we're saying medicine focuses on the detection and treatment of disease. So I just spent the first over half of this talk talking about detection and treatment of disease, but not necessarily about the experience of the illness, which is what I think was really highlighted in that New York Times piece that I put up. And so, but this is not to say that we are insensitive people who are just trying to detect and treat the disease in the short time that we've got, but we do need to be a bit more sensitive as well. So we're trained to learn the disease process, not the experience of being ill. But if we often think, if we treat the disease, the experience of the illness will disappear, which can be true as well. So how do we do this? So cultural competence can be a little bit limiting. As I said, it can stop some certain conversations. It's also important to know that culture is very fluid, so it can be difficult in that way. And it's important for both patients and doctors to realize that both parties are bringing different perspectives as well. As I said, it's not a checklist. So kind of one of the things that we absolutely would not want to do is to say, oh, I've got this plastic card and it's laminated, and I'm going to say, what are the 5 things we need to see when seeing, for instance, an Asian American patient? That's really not a way to build a good doctor-patient relationship, and I can't imagine any patient thinking that would be something that they would want. But what it really is the ability to inquire about patients, ask questions that show you that say, I'm caring about you as a patient and as a person, and not just as a part of group X or group Y. It affirms the patient as an individual, and it kind of and then it enables them to ask questions as well. So I think it generally makes patients more comfortable and helps make a better doctor-patient relationship. So this requires a bit of humility as well. And so it's the ability, cultural humility is the ability to maintain an interpersonal stance that is other-oriented, so at least open to the other person in relation to aspects of cultural identity that are most important to that person. So in this case, it'd be the patient. So this requires some self-humility, knowing that your own experience may not be is not the only experience, and suggesting that you too can learn things, and you can't know everything. So you can't know exactly what that patient's experiencing, even though you can know everything about the viral load and the e antigen and surface antigen levels. You can't know everything about their experience, but that you do want to learn more. So I think that's really the take home of this section of the talk. So in conclusion, hepatitis B is extremely common worldwide. Despite having treatments and vaccines, it remains a very major cause of morbidity and mortality worldwide. And the latest statistics I've seen suggest that there are over 800,000 deaths worldwide from hepatitis B. Chronic hepatitis B often happens from vertical transmission from mother to baby, and can lead to cirrhosis and liver cancer, and that's what is responsible for the majority of deaths from hepatitis B. Fortunately, there are treatments for hepatitis B that are highly effective and have very few side effects, and certain patients are subject to or would fit criteria for being treated. And there are vaccines that can really effectively prevent transmission of hepatitis B, And then screening high-risk individuals and treatment can prevent hepatitis B infections, complications, and hepatitis B related deaths. Given the geographic distribution and certain groups that are most likely to have hepatitis B and suffer the long-term consequences of long-term hepatitis B, it's important for providers to have cultural competency and some humility to give more effective care and really help patients out with the things that they're going through. So with that, I really would like to thank everyone for their attention, and I'm happy to take any questions. And I know my email is here, but I know that the group putting this webinar on is also can take questions as well if they come up a bit later. So thank you.
Thank you so much, Dr. Odenwald. I appreciate your slides and everything that you had to say. I have a question here to just start things off. First, what are the most common misconceptions you hear about hepatitis B, and how do you recommend addressing those misconceptions?
Yeah, I think there's a lot of different misconceptions. As there's kind of two different groups of there's kind of the acute infections, and then the chronic infections are really kind of the two different things that we need to kind of hammer home on. So, and I guess the most that is a really good question. So I think there are a lot of people that just don't show up because they don't know that they have it. So I think that's the most common misconception, is that patients don't know about it, providers don't know about it, and they're not really aware about it. And so they're probably the most common thing is that we just aren't thinking about it. And so it's not something that we're screening for as routinely as we should be. And so people will unfortunately often show up in our liver clinic with really advanced complications of hepatitis B. So that's probably the most common thing, is that people just aren't really thinking about it. How do we address that? Well, I think doing webinars like this is helpful. Kind of getting the word out there is helpful. And of course, trying to be a bit more culturally competent is helpful too, in making it so that patients are a bit more comfortable coming to the doctor and talking about things. Yeah, I think those are probably the most common thing, is just not thinking about it.
Yeah, of course, and thank you for sharing your thoughts on that. And then I have one more question. So recently, the CDC has expanded their screening recommendations to all adults 18 plus versus just the different risk-based screenings. Why do you believe that shift is important in, cultural humility and having, having more of a cultural conscience when screening patients?
Yeah, I guess it really just helps if we're recommending it to all patients, and it's a kind of universal recommendation. It probably removes some of the stigma around a hepatitis B infection, which many patients will not think of it, or think of it as something that they did to, so they engage in some behavior that results in it, and that's absolutely not true, as I've shown today, that most patients with chronic hepatitis B were infected at birth through no fault of their own. And so I think making it universal, it kind of removes some stigma that may be associated with it. It also makes it so that primary care providers are more aware of it and can make it as part of a routine screening. So patients will hopefully, if they do have hepatitis B, it will be caught earlier, before the development of some of these kind of life-threatening and devastating complications like cirrhosis and cancer. And so they can engage in treatment and kind of be engaged in hepatology care a bit earlier.
Yeah, no, thank you for sharing.
And I think it also, as I mentioned, the recommendation kind of about a year ago was really to universally vaccinate patients that are less than 60 years old. And so it also helps us find out who would benefit from it, at least recommending a vaccine to patients. So that would also prevent transmission that way as well. So there's a lot of benefit to just universally screening. Patients are usually getting blood draws anyways, at least in primary care, for various reasons. And so it's not an additional poke, it's just a little bit more blood.
Thank you. And finally, this is a question you might not be able to answer, so also would love to open it up to Sheila or anyone else. Do you know of ways to get involved with hepatitis B advocacy on a policy level? And what ways would you recommend people who want to get more involved in advocacy can?
I don't know all the specifics, but I do know that the American Association for the Study for Liver Diseases, or AASLD, has a lot of patient advocacy groups. So probably looking on their website at aasld.org would be a good way to start. But I think Sheila may know more about that on definitely the local and probably national level as well.
Great. Thank you so much. And there's actually another question. Is it recommended now to do a titer after a series is completed? It said years ago when I was vaccinated, that was not part of the process.
It's not routinely recommended to get titers after the vaccine is completed, but many healthcare workers, I know that from personal experience, many places will require you to get titers before onboarding, and not every patient reacts to the vaccine. Unfortunately, the overwhelming majority do, and it's incredibly effective at reducing risk of transmission and reducing rates of infection, but not everyone reacts to it. But it's not recommended universally to get a titer.
Great, thank you for sharing. And also, just to follow up on that policy question, another great way to get involved with Hep B advocacy is to take a look at Hep B United. They have a lot of things with policy on their website also, if you would like to get involved. Thank you so much. Sheila, are there any other questions that you would like to ask?
No, thank you both very much. I definitely enjoyed the presentation, and I hope others did as well.
Great. Well, thank you so much, everybody, for attending this webinar. Please sign up for our second webinar in this series, the perinatal hepatitis B webinar, May 22nd at 12 p.m. Central Time. It is also approved for AMA PRA Category 1 credit. When you do leave this webinar, you should be prompted to answer a short survey. These questions are to better inform the work that our organization does and Cook County of Public Health, and how to best support with helpful webinars like this one. So that officially concludes our webinar, and thank you so much. I will put the other sign-up sheet in the chat. Thank you, everybody.
Thank you.